Hello everyone, this is Dr. Usman Mustafa again. We have a very important and very popular topic today, which is regarding stents, coronary stents. What are they all about? As you know, almost more than 1 million procedures are done every year just in US alone. So many years ago, when there were coronary blockages noticed as a cause for heart attack and people dying, um, there was intention to develop a technique where you can go minimally invasive and try to fix those blockages. Almost 20-25 years ago, majority of the time it was coronary artery bypass surgery, but then certainly as technique developed, percutaneous approach, which is coronary angioplasty and stenting came. And I'd like to talk about stents today. What is a stent and how they are made, and what is the importance of these, and what we can do to make sure that we take care of people who already have stents. So if you already have stents, this is really a very important video for you. So let's talk about coronary stenting first before we go anywhere else in the body. So as you know, just to recap what we talked earlier, this is how the heart looks like, and these are the arteries of the heart which actually needs coronary stenting in case of angina or a heart attack. So this is the front artery, as we talked earlier, one of the earlier videos. This is the right artery, and then we have a back artery. The coronary stenting is required if you have more than 70% or so one of the major artery blocked, and then if you have an acute heart attack, in that case you can have these stents, and they actually keep the artery open. The stent structure, I hope you can see in the background, we have this is how the stent structure looks like. Many different companies have their own way of manufacturing the stents, but the most popular is where there is intertwined the small little wires. This is the stent which is actually expanded stents. You can see these struts, we call struts of the stents, struts, and this is the stent starts from there to there, and this is kind of a partial without the balloon. So both of these stents are without the balloon. You cannot take such a big hollow tube inside the body. So what the nice design of the stent is that it is mounted on a balloon, and that balloon is all squeezed with the machines, and then with a very fine, like 0.014 centimeter wire, we take it all the way up to the arteries. Inside, we go inside the artery, we leave our guide catheter here, and then the wire goes through the vessel, and then on top of that vessel, then we have a balloon which has a stent mounted on top of that. We take it there, and that actually balloon is then inflated. With that inflation, we have the result like this. So you can have this kind of expansion of the balloon, and that leads to expansion of the stent as well, and that clears the blockage. So in other words, all the rough material, which we're going to see in a second, actually is deposited and on the wall of the vessel itself. It's a blessing that the coronary vessels, as other vessels in the body, are stretchable, and that's a huge blessing, because imagine if they were not stretchable, we will end up cracking the wall of the vessel, and that's a very dangerous situation, lead to immediate death actually in most of the cases, because once you rupture the vessel and there is a leak, unless you are able to patch it up, which we have the ways, we can talk about some other time, but certainly that's a very grave complication. So if you look at it here, what we have is a vessel. It's a cross-sectional view, and this yellow stuff is a plaque, and this is the actual remaining lumen of the vessel, and you can see this is the outer wall of the vessel itself. And then after the stent, this is how the vessel looks like. The lumen is restored almost up to its original value, and then we have a nice blood flow going through the vessel. In this process, sometimes we do stretch the vessel a little bit, it becomes a little bigger. So if you look at the other view of this, so this is how the plaque is there, and then this is our wire. The wire actually goes first, and then we have on top of that wire we have a balloon, which is a whitish colored balloon, and the stent is on top of it. And then we inflate the balloon, which is this is the inflated portion of the balloon. You can see that, and that leads to the expansion of the stent. And once the stent is expanded, then the balloon, we decrease the pressure which is exerted from the outside, and the balloon comes out, and then the stent, which is here, stays inside the body, and then they keep the vessel open. But initially, when the stent came in, we got so excited. My God, this is the absolute solution of everything. We're not going to have a problem. But then later on, we found out that most of these stents actually ended up having problem, as that the atheroma started to regrow inside the stents. One of the main reasons was diabetes. So diabetic patients have a major problem. As you know, coronary vessels are at the most 2.5 to 3 millimeter. If we see a vessel as a interventional cardiologist, if any of the interventional person is watching this video, he will be very happy to note, and I'm sure we all get excited when the vessel size is more than 3 millimeter. So if it's 3 or more millimeter vessel, we feel excited that at least we can take care of it. The smaller the vessel is, the smaller, the higher the chances of instant restenosis, meaning the stent getting restenosed, or the thrombosis, or many other complications. So generally, we don't go less than 2 or 2.25 millimeter vessel. So 3.4, 4 millimeter vessel is a big blessing. So the amazing thing is most diabetic people do have a small vessels as well. Unfortunately, that's not a very pleasant situation. If you have a small vessel and diffuse disease, then certainly we have an issue treating those vessels effectively with the stents. So if you look at it, so then what we did is ultimately the techniques came in. So we have some of the anti-cancer drugs or some of the other drugs which actually slow down the growth of the intima, which is the innermost part of the vessel itself, and it starts from there. It goes from both sides, and it can cover the stent. Once the stents is covered from inside with the little layer of intima, then certainly the chances of its getting restenosis are rare, very small, although we have seen some late stent recoiling or stenosis in very few cases. But certainly, so now the techniques are such that we can actually put drugs on top of these struts, and that actually minimize the inflammation and the tissue response. And once those two objectives are achieved, then certainly the incidence of instant restenosis becomes fairly small. So this vessel, this is the, as far as coronary anatomy and coronary pathology is concerned, this is how we treat it. As you know, the vessels go all around the body. They can go to head and neck. So the neck vessels are also quite big, almost 6 or 7 millimeter. And then the same vessel goes to the arm and legs. So we, as interventional endovascular specialist people, are able to now, with the blessing of Almighty, we can actually fix those vessels wherever they are. So some people are expert in going into the brain, like endo-neurovascular specialists, and then interventional guys or endovascular specialists like myself, we can go inside the kidney vessels, bowel vessels, legs or arms, or wherever they are. So what we do is, with the same technique, we can go there and we can clean the vessel up. Sometime before you put the stent there, you have to clean the vessel a little bit with the balloon alone. So this actually takes care of some of the atheroma or plaque itself. So the stent and the balloon together, they can go easily. Once that happens, then the rest of the job is mostly easy, that we can actually restore the flow. So the same principle happens if you have a problem, blockages in the leg arteries, in the buttock arteries, in the bowel, in the renal or kidney arteries, or wherever they are. So once we can percutaneously go into those vessels and fix them. And believe it or not, this is some of the magic moments. Once you clear those blockages and patient feels better, this is a huge and a big relief for all of us. Hope you enjoyed the video. If you have questions, you can always comment. Thank you so much, and thank you for watching.